We all know that the toric IOLs, they were first implanted by Dr. Shimizu in 1992. But it is in the last 8 to 10 years that these IOLs, they have been used by almost all the surgeons, because now the profile of the patient is changing. They demand unaided and uncorrected distance visual acuity at least. So, and now we are not only a cataract surgeon, we are a refractive cataract surgeons. And various studies have estimated that 15 to 29% of the cataract patients, they have more than 1.5 diopter of corneal astigmatism. And what this astigmatism does is that it decreases down the visual acuity and the quality of vision in these patients. Can I have the pointer, please, here? So if you look at the left side, this is the vision with the astigmatism of 1.5 cell, and that on the right side is the vision with astigmatism of 3 diopter cell. So it's definitely an error, and as a surgeon, it's our responsibility to correct this corneal astigmatism along with the cataract surgery. Our counseling for the cataract surgery of patient always start after doing keratometry. Because once you finish your counseling and you do your keratometry, you realize that patient has astigmatism which requires to be corrected. So the whole process changes. Patient also had doubts in his mind. So now we have the platform of acrylic hydrophobic IOLs. And these IOLs, they are known for the addition to the capsule and have a profound shrink wrap effect. And this profound shrink wrap effect is essential to maintain the centration and to prevent the IOL from rotating. And this is the IOL in the capsular bag. So how does a typical toric IOL looks like? They have these toric IOL laser marks on the posterior side of the IOL, and these marks, they reflect the least power of the IOL, and these marks has to be aligned with the steep axis of the cornea. So Dr. Pandey was talking about the lens decentration and the aspheric IOLs. For toric IOLs, at least we required a design which is very useful, because we know that every IOL typically does not sit on the visual axis. So this is the study which shows these are the aspheric IOLs. So this is a spherical IOL. Tell you that the aspheric IOL designs, they are very, very sensitive to the decentration. If you look here at the point spread function, even 0.2 millimeter decentration, it decreases the PSF, and 0.4 decreases it further, whereas a spherical IOL, this is not decreased. So effect of decentration is more in aspheric IOL as compared to spherical IOLs, whereas the effect of the tilt is not that much as in aspheric and aspherical IOL. So what I loved about the design of this Hoya ABC design, this what is called as aspheric balance curve design, is in the center of the IOL is minimal negative aspheric. It's almost aberration free. And the outside this central zone is a standard negative aspheric minus 0.18 micrometer of aberration. So you have all your optical point and the visual axis in this central area, so that even if decenters to 0.4 millimeter, it doesn't affect the PSF or MDF graph of the patient. So these are the graphs which are showing this. Now coming back, the toric IOL are available in different powers, and this is the power at the IOL plane, and it uses a fixed standard ratio of 1.46 and convert it into the power of which is available at the corneal plane. So if you implant an IOL which says the 3 diopter at IOL plane, it means you will correct 2 diopter at the corneal plane. Axis notation we have to remember, it goes from left to right, and there's a left eye 0 to 180 degree, and right eye 0 to 180 degree. There's a notation which is used. So coming to the keratometry, as Dr. Monisha mentioned, that you can do manual K, automated keratometry, topography can always assist you, and we always do topography, and now we have started doing tomography of all our patients, because the effect of the posterior corneal astigmatism is also very important, as Dr. Douglas Koch has come out with the results. that if you only use the anterior corneal astigmatism, the problem with all the manual keratometer or auto keratometer or topography or IOL master is that they only use the anterior corneal curvature and then use the fixed keratometric index of 1.3375 and assumes the cornea as a single surface. So, but in reality, this is not true, because especially after post-refractive surgery, this ratio changes, so you can't directly imply these readings for calculation. So coming to IOL power calculation, immersion, of course you have to do or optical biometry. Forget about contact biometry. So once you do this, you have to determine your surgical induced astigmatism. Dr. Hill, you go on website drhill.com, you feed in data of your 30-40 patients of right eye as well as the left eye, so that you will come to know what is your SIA, 0.3, 0.4, 0.5, whatever is your SIA. Why this is important? Because this is how the typical online calculator looks like. So you have to feed in your flat K of the patient, the flat axis, the steep K and steep axis, your surgical induced astigmatism, your incision location, this is left eye, and my incision is at 20 degrees, and your IOL spherical power. So, what we are interested in is that the patient has pre-op corneal astigmatism of 4.32 at 149 degrees. When we put any incision, we also induce astigmatism. And what we are inducing is a 0.5 diopter at 110 degree. So, what we are interested here is the cross-cylinder result, or what will be the final astigmatism which is required to be corrected, and that is 4.45 at 148 degree. So this is our axis where we are going to implant the IOL, we are going to align these toric marks, and this is the astigmatism which is effectively required to be corrected. So after that, there are three options which are shown in this calculator. If we use the cylinder power 6 diopter at the IOL plane, we get the correction of 4.12 at the corneal plane, and residual is only 0.33. Okay, and this is the option. Another option, if we want to undercorrect astigmatism or we want to overcorrect astigmatism. So now we have our axis, required axis, where we need to implant it. These are different data of the patient. Now coming to the, so once we know that this is the axis, we are going to implant the IOL. Now before surgery, we need to mark the reference marks on the cornea 0 and 180 degree. There are various methods which can be used. Either you can use the ASICO bubble marker, or you can use the pendulum marker, or you can use nowadays electronic markers are also there by Akahoshi. But what I like most is the marking on the slit lamp. So I narrow down the slit beam in undilated pupil and use a 26 gauge needle to put a scratch mark on the epithelium, on the cornea, on both the sides. Here I am putting the scratch marks. So what happens that your scratch marks always remain there, even if your ink fades away. So once you put these scratch marks, put ink on the tip of the 26 gauge needle and stain it. So now you have very thin 2 marks, which are very, very well taken up the stain as well as there is abrasion on the cornea. So once you have your reference axis, now this is the Mendes degree gauge. It's better to use the titanium one because the steel one gives lot of glare, and always try to mark the cornea when it's dry. Again I use the 26 gauge needle, put ink mark on the tip, and just put a small mark on the desired axis. This is somewhere around 83 degrees. So once you have these 2 tiny marks here, then use a Boris meridian marker. This is my axis I'm marking here. So this is the Boris meridian marker. You can join these 2 marks with this. See, the cornea is dry. Wait for 4-5 seconds and then wash your cornea. So this is the steep axis of the cornea where we need to align our toric IOLs. So now coming to the toric IOL implantation, If you use OVD, fill with this. This is the preloaded Hoya toric IOL. It's very easy to use. You just need to put some viscoelastic, advance the IOL. It's a screwing type of injector system, and this is FDA approved. It goes through 2.1 millimeter. It has a beautiful uniplanar delivery of the IOL. So once you implanted the IOL, it's very essential that you take out all the OVD which is there, especially behind the IOL. Now you go behind the IOL, remove all the OVD, and use irrigation cannula and the Kuglen hook to rotate the IOL and align it to the steep axis. I just showed this for the sake of audience. What I use is the hydroimplantation technique. I don't use any OVD to implant IOL. That's my technique, which was published in JCRS 2010. I just put irrigation cannula. This is the Acrisoft toric IOL. See how nicely it goes. This irrigation fluid coming from irrigation cannula, it maintains the anterior chamber depth and the capsular bag. And moreover, this irrigation cannula over the IOL optic, it prevents any tilting or inversion of the IOL. So once you have the leading haptic and the optic in the capsular bag, you dial the trailing haptic and rotate the IOL to the desired axis. So there's another video. Okay. There's a beautiful study by Savini who showed that was the influence of the axial length and corneal power on aesthetic power of the toric IOLs. As I said, in normally a fixed ratio of 1.46 is used to convert the IOL power into the corneal power. But in reality, if axial length increases and the keratometry increases, this ratio changes. So you can see, I give you an example, if the axial length is 30 and keratometry is 48, the ratio is 1.82. It's not 1.46. So if you have a patient who has axial length of 30 and K of 48, you want to use a T9 model which gives correction of 6 diopter at IOL plane, which corrects, if you use a fixed ratio of 1.46, 4 diopter at corneal plane. But in reality, you won't get this correction. Why? Because this ratio is not 1.46. This ratio is 1.86. So now the re-correction which you get is only 3.2, not 4 diopter. So this is a very good table which can be used in high myopes or this. So by any chance, if you have any misalignment or whatever goes wrong, you can always go on this website, astigmatismfix.com. So what you need to feed in here is your current refraction, which is there, toric IOL, its axis, and then this tells you that if you rotate the IOL by so much degrees, where you have to rotate to get the least amount of astigmatism. There is another website, assort.com. This is a very good website. Again, you feed in your keratometry data, your refractive error which is there. It will tell you how to, clockwise or counterclockwise you have to rotate in the toric IOLs. So, coming back, the toric IOLs, ideally they are used for the regular astigmatism, regular bow tie astigmatism, but you can use the toric IOL in patients of keratoconus. This was a patient which we operated 8 months back. You can see he had astigmatism of 4 diopter, and the age of the patient was 48, 50 years. He came up with cataract. So, after implanting toric IOL, he has a very good correction of 6/9 vision with only 0.75 diopter cylinder. These are the so the points which has to be taken care of when you're implanting toric IOL in keratoconus patient is that good vision with not with rigid gas permeable contact lenses. You have to avoid multifocal IOLs because they can cause loss of contrast sensitivity, which is magnified by corneal irregularity. And most of the patients of keratoconus, they have high negative spherical aberration, so you need to choose spherical IOLs or the IOLs which have neutral asphericity. If keratoconus is severe and progressive, it is not a case for toric IOLs, or if central corneal scarring is there, you should not use toric IOL. Toric IOLs are also used in post-keratoplasty patients. I won't go in detail because we are running short of time. So, okay. So to conclude, the success of toric IOL depends on the accurate measurement of your astigmatic power and axis, accurately locating the axis in the eye, placing the toric IOL correctly in the eye, and preventing or correcting any post-operative misalignment. So with this, I'd like to invite all of you to our instruction course, which is exclusively for toric intraocular lenses, on Sunday, Hall F, same hall, 10 to 11:25. Class Fenbaum, Suresh Pandey, Rajesh Sinha, Sanjay Chaudhary, Anand, are the co-instructors. Thank you so much, Dr. Vinder, for giving this opportunity. Thank you.